several things that we can look at in the drawbacks of treating cancer. The primary three things that I can think of is, one is tolerance to therapy, which is a huge issue in the context of patients, mainly the elderly patients, which is a huge patient population. The second one would be in the context of monitoring for response, because if you don't accurately monitor for response, you could have patients being exposed to a drug which is not really effective, or a combination of drugs which is not very effective, and put them at the risk of having the toxicities without the clinical benefit. The third biggest thing is the mechanism of resistance to the drugs and combinations that we use. So those would be the three top things that I can think of in the context of what happens in my clinical practice. With pancreatic cancer, which is what we initially looked at in the context of how we would treat this and how we would monitor it, the CA19-9 as a tumor marker is present in a majority of patients. However, about 17% of the human race does not produce the human Lewis antigen. Within that subset of patients, even with the ones that produce the CA19-9, which has been the monitoring tool for us as a serum marker, there are huge variations that can occur, either from the context of having a biliary obstruction, having an infection, having an inflammatory process that's driving this, hence making it a very inaccurate test, especially when you're trying to manage these patients. Therefore, we were seeking to find a tool that could be easily administered but reliably monitored over a period of time and correlate that to the radiological markers that we know of. It was an unmet need, and using it in that patient population was the perfect way to start this. When we think about recurrence, we can look at it in multiple buckets. You can look at it as recurrence after adjuvant therapy. You can look at it as recurrence during adjuvant therapy. You can look at recurrence during metastatic disease. You can look at recurrence in the neoadjuvant setting. And in all of these, what we tend to use at this point is using the radiological imaging, which can lag by several weeks, because most of our scans are done every 2 to 3 months. So having a tool that you can monitor from a cycle-to-cycle basis, if reliably done, and if it can be reproduced, would be an immense benefit for patients, mainly to help them not undergo treatments or procedures which may or may not help them. So therefore, it is of utmost importance. The monitoring of this is a dynamic process. It is not a one-time biopsy, but it's a constant monitoring of this, and hence identifying during recurrence, identifying these actionable mutations becomes of paramount importance, because we know that the genomic landscape changes over a period of time. And during that period of time, you could have resistant mechanisms which are causing the tumor to be more resistant to the current therapy, and therefore identifying these actionable mutations is important, especially in our day of personalized medicine that we are in today. You need to identify recurrence early, but also when you do identify recurrence early, you need to figure out if there's any change in the genomic landscape, and therefore the identifying actionable mutations comes into play there. So it almost goes hand in hand as two of the most valuable things that we could use in the current context.